We're getting there, everyone. The answers are rolling in. Okay, so I believe the results are in, and for these first two questions, beginning the break here, looks like it's a pretty 60-40 spread in terms of if you've attended an elder abuse summit before. And this is one of the, I think this is the 10th, if I'm not incorrect there, Jill, but we've done these a lot. We took a break during COVID. We've done some virtually lately, and it's nice. We get good participation. Right now, we've got 197 participants, and hopefully that number will continue to go up. And in terms of our business and organizations, nonprofits, a few law enforcement, state agencies, legal, domestic violence, a little bit of housing, only one for-profit business, and some others. So thank you very much for those poll questions, and we will get started here with our next presenter is Dr. Stuart Lewis to talk about self-neglect. Dr. Lewis, are you ready to present?
Yes, I am. I'm just going to make sure that I can share my screen. And it looks like I can. So there we go. First off, thank you all so much for coming, although it's like on Zoom, so it's always sort of funny to me. I do miss sort of actual people with actual legs and feet and shoes, and I can see when they fall asleep or see when they're doing other things. But I'll do my best, try and keep you engaged and interested and really quite curious about what you think, because we'll be talking a little bit about some stuff that we know, some stuff that we've come to know, and then some stuff that I'm sort of testing out a little bit. So really interested in what people think, and I'm so excited by the broad range of backgrounds and experiences that all of you bring to this conference and to this important subject. So what we talk about when we talk about self-neglect, and I say apologies to Raymond Carver. Carver was a wonderful short story writer and wrote a book called What We Talk About When We Talk About Love, and it's quite a remarkable book. I think it's from the 80s, and I would refer people to it, but apologies to him, really. And my question to all of us is it time for a new paradigm when we think about self-neglect? And I'll get into that as we move forward. So what are the learning objectives? I'm told we always need learning objectives. My colleague David Burns would call them goals. But I want us all, hopefully by the end, to be familiar with the definition or definitions of self-neglect, understand the relationship of self-neglect to other types of elder abuse, and begin to ask some questions about how we think about self-neglect, how we think about how we care for folks who are in those circumstances, how we think about it ourselves, how we think about our system's approach to it. I have no significant conflicts of interest, and I guess we can get started. The talk may not go as long as I imagine, but that will give us more time for questions, I hope. So from the Elder Justice Act, this is the definition of self-neglect. It's an adult's inability due to some physical or mental impairment or diminished capacity to perform essential self-care tasks, including obtaining essential food, clothing, shelter, and medical care, obtaining goods and services necessary to maintain physical health, mental health, general safety, or managing one's own financial affairs. And often this is someone who we consider a vulnerable adult. And most of what I'll talk about today are folks over 60, because obviously we do know that Maine APS serves younger individuals who also may fall into these categories. But for us today, we'll think about those individuals over 60. And it's important to recognize that in the Elder Justice Act, self-neglect was separated out from other forms of adult maltreatment, physical abuse, emotional abuse, financial abuse, other form, all the other neglect. That's a separate area. And in fact, the CDC defines that, the Centers for Disease Control defines that as sort of elder abuse, those 5 categories, not self-neglect. So that's important to think about. And as I think we'll come to see, this is a really, maybe it's a bad pun, but sort of a messy area, because there's a lot of confusion about definitions, causes, what it really means. So other sort of APS organizations, this I think I got from Washington State, define it differently. What is self-neglect? Lack of self-care to the point where it threatens your personal health and safety, neglecting personal hygiene, health of surroundings, inability to avoid harm as a result of self-neglect. That's actually quite important, and I want us to sort of begin to keep that in mind. Failure to seek help or access services to meet health and social needs. It's an interesting perspective. It's the person's failure. It's not actually ours. So that's something important to think about. Where is the telescope being focused on in this situation? Or maybe the microscope might be the better word. And an inability or unwillingness to manage one's personal affairs. And those are quite useful, and those are things that we think about quite regularly. This is from a paper from 2006, which I think is sort of an interesting thought, because it talks about whether there's intentional or non-intentional behaviors. And it talks about how we view self-neglect in its social and cultural accepted standards of what we would consider self-care. So it's an inability to maintain our social and culturally accepted standards of self-care with the potential for serious consequences to the health and well-being of the person, and perhaps even to their community. What I like about this particular conception is that it takes it out of the individual point and brings it broader into where do we live? What are our values, preferences, beliefs? What do we bring to this particular circumstance? Because in some situations and living in other places, what someone might consider neglect might be not neglect at all. So like many things, and I think it's sort of medicine is late to the game on it, like you have to think about where people actually live and what are their circumstances, what are their beliefs, and how do we meet them where they are? So I think this is an important way to begin to think about it. And it also suggests that many of us, even individually, have different ideas of what that all means. So my idea might be different than the chief's idea, it might be different than, I saw Polly from EAM on here, might be different from her ideas. It's nice to see some faces that I know on the Zoom. Because I'll know that they'll get back to me tomorrow or the next day, say, what were you talking about? Anyway. So when we look at national data, and this is from the National Adult Maltreatment Reporting System, often called NAMERS, and they put out reports pretty much every year, although they are, it takes them a little while to do it. So this is the last one we have, which is from 2021. And it takes, and all statewide APS will report to NAMERS. So we get a lot of interesting data from this. It's not yet public. I would love it to be more public database so that many of us could look at it if we had questions and concerns. CDC data, very interestingly, so much CDC data is public, which is a really important thing for researchers and people interested in public health. So this talks about what the APS, statewide APS reported, almost 1.4 million referrals of alleged maltreatment. But I want us to focus on this box here. And of course, this is one of first of many unnecessary PowerPoint animations, but here we go. 50%, half of all allegations are self-neglect. That's what we see. That's what all of you see. That's our experience. It's a massive number, a massive number. If we delve and dive a little bit further into this, when we look at substantiated cases, overwhelmingly, APS is seeing self-neglect. Self-neglect is the major thing you folks see. And I know there are people who are from APS on this conference and others who are not, but we all have an interest in this. And APS fundamentally is the social organization that is dealing with this. Those are the folks who are investigating, trying to help, managing, and many times, I must say, probably getting quite frustrated by these circumstances. You can add up all the other types of maltreatment, and it doesn't quite make it to self-neglect. It is a little bit like the elephant in the room that we have a hard time talking about. So I'm really quite pleased we're getting a chance to at least thrash through some of this. And I don't think we're going to come to, overwhelmingly, clear conclusions, but I want us to try to keep thinking. So this is to say, this is a massive problem, both in Maine, which we'll see a little bit later, but also nationwide. Oops. And when we look about substantiation, it also follows, right? Has the highest substantiation rate of any other forms of abuse or neglect. So again, this is a substantive amount of time folks spend on trying to help people in our community who are not able to care for themselves, or who are not caring for themselves, or who we believe in our judgment and beliefs are not caring for themselves in ways that we find okay, and also impact our community, right? I mean, folks who we see in a parking lot living in a car, we can't really pass that by. That's something that impacts us, right? And I think all of our natural human tendencies would be like, what can we do? What do we do here? So I see Selden has raised a hand, but if you do have questions, please put them in the chat and we will definitely get to them. So thank you so much. So what are some of the common characteristics of folks who end up being labeled as self-neglectors? They're more often women, and honestly, it's probably just demographics. Women do live longer than men. Often there's some depression and some confusion, which may relate to some cognitive impairment. They're older, they're generally frail. Oftentimes there's a history of some alcohol or drug use issues. They may be active, they might be in the past. And we often think of the history of poor personal hygiene or living conditions. When people first began to describe this in the 50s and 60s, a lot of it came from Great Britain, and people had called it squalor syndromes. There was something called Diogenes syndrome, which you look in the medical literature. And that was actually a very poor name. Diogenes was a famous Greek philosopher that, while he did not dress well and was often in his toga and was dirty, he was constantly talking to people and he was constantly engaged. So the social isolation that we'll see with many times with folks with self-neglect, it really was the wrong name. And we don't really use that anymore. Though there was a time in medicine where everyone loved a good eponym. So what are some of the consequences? So from my perspective, as a physician, we're quite concerned about people who are living under these circumstances. There's a much higher rate of emergency department usage, and we know that folks who use emergency departments don't get as good care as folks who have a general primary care provider. We know that the cost of that care is much higher. There's a 5 times rate of nursing home placement if substantiated by APS. So these folks end up in long-term care, which also has a significant financial burden. And also, honestly, most people don't really want to end up in a nursing home. People value their independence, their freedom, living in their own home. So this is a substantive change in people's lives. And if you have substantiated self-neglect, your risk of dying within the next year is incredibly high. It's really, it's not, it's something that we don't think of regularly, but it is a real risk for someone's health. Higher rates of hospitalizations, and then higher rates of rehospitalizations. And if there's anything a hospital system is really anxious about, it's rehospitalizations, because those are folks that they often get financial penalties on. Medicare and Medicaid will say, why are you rehospitalizing people? It's a major burden for them. And then there's sense of personal distress. And it's very hard for caseworkers. There's a lot of literature among medical providers that folks who are self-neglecting, folks who they can't really provide the care for, or you say, please do this, and they never do it, are quite stressful and are really a source of burnout for many folks. So the consequences are not just individual, but they're on the folks who are surrounding them. They're in the environment, the sort of bubble around these people. And I think that's what makes it such an important thing, I think, for us to really think about and try to address. So this was a very interesting study by folks at Weill Cornell in New York. They took about 66 people, I think, who were cognitively intact. So these are folks who were known to self-neglect, but cognitively intact, meaning they didn't have a significant dementia, and they were all basically interviewed in a structured way to understand backgrounds, history, and what may have, what are some of the characteristics that can't really say define them, but what are some of the characteristics that are more common in at least folks in New York City who were self-neglecting? And often they've been a victim of some psychologically traumatic event, loss, separation, abandonment. Oftentimes there's been violence, physical trauma, or sexual abuse. There's exposure to war or political violence. I mean, I think that we may see this a little bit more in New Hampshire, Vermont, Maine, where there are more folks who have been in armed conflict than in New York City. So I think these numbers are point in directions, but I don't think we can quote them as exact. And then there's prolonged mourning, often of some loss. And then I think also there's a lot of overlap between these experiences. But I think that this gives us some one lens of looking into what the sort of past experiences are. And then what they characterize as behavior patterns, but I also might think of them as sort of like social experiences as well. Significant financial instability. These are people who are economically dislocated, struggling with behavioral health disorders, lifelong mental illness, which may or may not have been treated well. There's mistrust and distrust and avoidance of the medical establishment, for sure. And then there's substance use and dependence issues. So you can see that there's a lot of overlap between these, but oftentimes these are folks who have probably some underlying personality traits. They've had some life experiences that have created a milieu where some of what we are seeing later on as somebody who's self-neglecting has come to begin to build. There's also a good deal of, well, I can't say a good deal. There's also some evidence that the behavioral characteristics, the way people are in their lives occurs well before sort of the age of 60, when, we might consider them part of this. These are people who have had these traumatic experiences, who we might not see as, quote, severely self-neglecting, but they're moving toward that. So younger individuals may see them earlier on the spectrum that then may eventually, over time, end up being seen by APS. There's a bunch of themes that have come out of this. That was the study from Weill Cornell. There have been a bunch of other studies trying to understand what people who self-neglect think, and essentially interviewing them. A lot of this work comes from Great Britain, something called the Care Institute. They have some different language for things, but they're also quite interested in folks who are not sort of caring for themselves. And of course, most people who we see don't think of themselves as self-neglecting at all. Absolutely not. What are you talking about? I sometimes joke, because I came from New York. I know it's from away, and practicing in New Hampshire. And I think one of the biggest changes I've noticed is that in New York, I would have to convince people not to do a test. And in New Hampshire, I have to try to convince them to do it because they're sort of like, nah, I don't need it, I'm fine. So that's not self-neglecting, but there is a sort of way that people are like, no, I'm fine the way I am. And they describe where they're living, their home, as their palace. I use the word palace very specifically because that came up a bunch of times in the literature that I reviewed. So it's an interesting word, but I think it reflects how people feel about their environment. Self-control and self-sufficiency is essential, absolutely essential, and may believe that the services that are offered don't really respect their lifestyles or preferences. You can't really get someone to do something they're not going to want to do. And social systems have, in general, failed them in the past. And this is this idea of systems neglect really comes from some of the elder service connectors, elder advocates from the Elder Institute of Maine, who really began in some of their work with the RISE program to hear the idea that folks who had been referred for self-neglect really felt like systems had neglected them. So there's a way that there's an experience of the world around them as well. Interestingly enough, they really have very highly positive self-appraisals, a strong spirituality. I think we all know that they have a very deep connection with their pets. And that's something that comes out quite frequently. And sometimes there can be many, many pets, and sometimes there can be pets that we wouldn't necessarily consider pets. But that's part of it. And this isn't just in Maine, this is throughout the nation. And then the feeling of suffering losses and uprootedness throughout their lives. I think the uprootedness is a really important thing to keep in mind, because these are people that may have, had childhoods where they're living in a lot of different places. There may be folks who've been in foster homes. There may be folks who lost parents, lost grandparents. So the dislocation, those traumas, which may not have been well supported in the moments, are also important in what's going on here. Oops. I love this slide. I know it's busy. People have been thinking about what causes this circumstance for a long time. And there have been a lot of things. Basically, they've thrown every possible thing out here as a cause of self-neglect. I particularly like the idea that somebody thought it was related to vitamin E levels. I mean, so yeah, we're going to give people vitamin E and they're all of a sudden going to get better. Oxidative stress. I mean, certainly depression, diminished social networks, that's more of the phenotype. That's more of what we see. Physical poor health, poor mental health, economic dislocation, I think, is quite important. Lack of access, absolutely. We do know that there's a whole bunch of people with cognitive dysfunction that represent a really important subset of individuals with self-neglect, pain syndromes, functional impairment, traumatic. I mean, there's a lot of things thrown out here. And oftentimes when you see a lot of hypotheses, it sort of means we don't actually know what's going on. So I think that's also important to think about. And then the idea of a geriatric syndrome, which of course makes geriatricians very interested. And a geriatric, whoops, let me go backwards. A geriatric syndrome, oh, whoops. Anyway, a geriatric syndrome is a combination of illnesses or conditions that are particular to aging. So we think about frailty as a geriatric syndrome, falls as a geriatric syndrome, delirium in hospitals is a geriatric syndrome. So people trying to say, well, self-neglect is a geriatric syndrome. I think part of the problem with it, it goes back to some of the other slides we talked about, is it doesn't really take into account the social or cultural context of these individuals. But I think that for the most part, what we see here is a one of deficits, disease, and disorders. So it's a sort of, how do we say, it's slightly blamey, I think, and it's about what's not present. It's not strength-based. It's not really taking on the individual as we see them, but the individual as a problem. So this meta synthesis by you, I thought was quite useful. A older self-neglectors desire to be treated with normalcy and are actively interacting with their environment and reacting to threats to their identity. They want to be seen as people. I mean, this is not rocket science. You know, who doesn't want to be seen as a person? Who doesn't want to be seen as human? Who doesn't want to be seen as having value and agency and autonomy and interest? I mean, it's just basic. It's basic to all of our human needs. And we need to understand self-neglect within the context of personal, environmental, and living circumstances. All the things we talk about, all the things we know. We want to be treated in ways that are consistent with our beliefs and preferences. And we should think about how do we do that with folks who are really in some degree of, it's like friction between themselves and the world around them. Your neighbor who might have 12 cars in the backyard, and all these things. These are places where as individuals, we come together, but as communities, we have to figure out how to work with each other. So it's sort of, I think this is, it's crude, but it's like what we see and what the person sees. We see squalor, they see a palace. We see hoarding, they see treasured possessions. There's no question the possessions in the people's homes are really quite important. And I think about that show Hoarders, which I know was quite popular, and I've only seen like 1 or 2 episodes of it, but it breaks my heart because it feels sort of exploitative and cruel. We see isolation. People see self-sufficiency. I see unattended medical problems. The person really sees, why do they want to trust me or a health system that hasn't helped them before? We see, what about your family? And that person probably sees histories of betrayal. So how do we bridge this gap of what we see and what the person sees? That's one of the challenges I think all of us face in this situation. So this comes from a conception from the Care Institute in Great Britain, which I really liked. The 3 aspects of this are knowing, being, and doing. So the first step is to try to understand the person, respect them, be empathic, be honest, be reliable. Reliability is essential. If you say you're going to come back, come back. If you say you're going to call, call. Don't make a promise you can't keep. And start small, right? And when something else big is needed, talk to people, figure it out, get a team together, right? So if you feel like if you're in a community and there's something you need to do, speak to a local religious leader, speak to someone maybe in the AAA, speak to your local law enforcement folks, try to get a team together to understand what will happen and how you might approach a bigger problem. But if you start small, you'll often avoid a bigger problem. And maybe we'll get to a little bit of my other sort of thing, which is things that are person-led. How do we let the person lead us? How do we help them go where they want to go? With some degree of boundaries, of course. So I can't talk about elder abuse, adult maltreatment in Maine without talking about RISE, which is a program we established a few years ago in collaboration with APS, thanks to an Administration for Community Living grant. It is now amazingly a statewide support system working with APS. I can only thank the hard work of all the APS workers, the hard work of all the folks at the Elder Abuse Institute of Maine. Really amazing work. RISE takes into account the idea of being, knowing, doing, in the idea that the focus is to repair harm, to inspire change, to support connection, and to empower choice. I also think it's important to think about it as it works at the relational level, like individuals and other individuals. It works at the individual level, who that person is. It works at a social level, their communities, the supports around them, and it works at an environmental level. Like, what are the systems that they're interacting with? Health systems, law enforcement, APS systems. How do we begin to put these together in ways that will help them? It really focuses on engagement and goal setting. Engagement is really a mechanism of establishing trust. And it's usually something where you start really slow. And that slow could literally be getting somebody's cat to a vet. The slow could literally be, you like French fries, I'm going to bring you some French fries. It really is, how can you ask someone to make a major change when you haven't even helped them with the little things? And so you begin slowly. And just as sort of a piece of history, we began RISE with the idea that a lot of it would be useful for sort of the CDC defined abuses, financial abuse, emotional abuse, physical abuse, and it is. But what we got from APS was a lot of self-neglect. But that was because APS sees a lot of self-neglect. And RISE turns out to be quite useful because the techniques that work in interpersonal problems also work with individuals and their own issues. So some of the data that we had from the pilot study, which was over 2 years of data, and I'll just try to explain this as best I can. The bar on the left, that says that if you just had a history of self-neglect substantiated, and you were seen by APS, you had about a 40% chance of coming back into the system over the 2-year period. If you were part of RISE, if you're part of the APS RISE collaboration, that dropped to about 11%, a significant reduction in reinvestigations. And that, I think, is part of why RISE is now statewide and why we're trying to test it in other places. We want to make sure that what we saw in Maine is something that we can replicate and something that's real. Right? We want to know, like, what are we doing and how do we do it and how do we bring it to other places? So that's an important thing to think about. It reduces the risk of reinvestigation. It reduces coming back into the APS system by about 4 times. How this, what this results in for people's lives, you don't quite know yet. We're going to try and get more data on it to see how it might impact people's healthcare, how it might impact people's living situations. But we think that this is a real, we feel quite comfortable that this is a real effect. Oftentimes we think about safety versus autonomy. And I've never really liked that dichotomy. So I try to think of it as safeguarding and what's our duty to care? Like, how do we as individuals, as humans, as neighbors, as professionals, what is our duty to care for the person? And we know that persons who resist medical and social interventions are really difficult to care for because they're basically calling into question one of our fundamental goals is to act for the good of the person. And also, there are people on this conference who I know also know that not just they're acting for the good of the person, but they're acting for the good of the community as well. And I think that's one of the real challenges of law enforcement, that you really are looking at not just the individual, but how does this individual interact, and influence the community around them. I think overall, this is something everyone I think is familiar with, is it needs to be strength-based. I think we get lost a little bit on ideas of capacity. Just because someone has capacity doesn't mean they shouldn't be helped, right? They might refuse our help, but that's not an excuse for us to try to do better. I mean, it's not just an exit ramp for us to say, well, okay, fine, you got capacity, I'm leaving. And the only way to manage all this is to respect people's choices and try to help them stay safe, try to essentially help them do a little better with caring for themselves, I think. So I've been left with a whole bunch of questions about self-neglect, which is the most common form of adult maltreatment. I remain a little confused as to why the CDC doesn't measure it. Why is it not discussed when we talk about prevalence? We talk about prevalence of other forms of adult maltreatment, 1 in 10 or 1 in 6, depending on who you read, but nobody really talks about self-neglect. Why aren't people giving money to actually study this and help it? I mean, they're doing a little bit better, but it's not anywhere near the the problem is so massive, the funds that are given to it don't reflect the actual problem. I sort of talk to doctors a lot and wonder, why are there no actual ICD-10 codes? That's how we make, like, you come in, you see a doctor, you've got, influenza, there's an ICD-10 code for that. You have diabetes, there's an ICD-10 code for that. You have hypertension, there are ICD-10 codes for other forms of elder abuse, for financial abuse, for physical abuse. There's no ICD-10 code for self-neglect. We can't actually code it. And when you think about hospital systems, if you can't code it, it doesn't exist. So what's going on there? And why do we see this differently? Why somehow are we seeing this differently? Those are some of the questions that I'm troubled by. So I want to take us back to Maine, because that's where we are. And that's where a lot of our experience is. And I really have to thank Erin Salvo and all the folks at APS who provided us data initially, because none of this work could exist without their belief in the importance of understanding what they see, and our belief in trying to get some answers from it, trying to answer questions they're interested in. So this is 4 years of data for people with substantiated self-neglect. This is the first time they enter their first substantiated allegation. Over half are only self-neglect, a massive number. What was interesting in our work, and this is work that we published pretty recently, was about a quarter of them are both self-neglect and some other form of abuse, right? So these are co-occurring types of problems, and that's not often thought about. And then under a quarter or so are purely the sort of plain CDC type of abuse. So if we think about the impact of self-neglect on the folks in Maine, over 3/4 of them have some component of self-neglect. It's a very big group of people. When I say it's the elephant in the room, it really is. I mean, how do we not begin to really focus on this? How do we say we need more help? We need more help with this. And when we look at it in a different way, I do a lot of stuff with data and statistics. I sort of love it. This is looking at, if we take all the folks who get to APSCs, and we say, if we just look at the people whose first time APS sees them is self-neglect. The purple line is people without, I'm actually pointing at the purple line on my screen, which of course you actually can't see, but anyway, there we go. The purple line is folks who do not have substantiated self-neglect. And I choose purple because that's the elder abuse awareness color. The blue line is folks who enter APS with the first substantiated case of self-neglect. What are their chances of getting some other form of abuse? It turns out quite high. There's a significant difference if you show up with substantiated self-neglect that you will end up with another form of neglect within a year. The orange line are folks with unsubstantiated self-neglect. So even if it's not substantiated, it may be at risk, there may not be enough to substantiate. They may have been sort of cognitively intact, and so they don't quite get substantiated self-neglect. They still end up at a significant high risk of developing sort of CDC-defined abuse, physical abuse, emotional abuse, financial abuse, neglect. They are at risk. It is a true risk factor. You can look at it a separate way, and that's from this slide, which is a little bit, I know it's a little bit number heavy. So basically this says, if you end up in APS with a first allegation of self-neglect, so that's substantiated, in a little over 200 days, you'll end up back in APS with a CDC-defined case of abuse. Don't worry about this thing called incident rate ratio. Epidemiologists, that's important for us. But the other thing I want you to look at is the attributable risk proportion. And what does that mean? That means how much of our classic types of elder abuse, financial abuse, neglect, emotional, how much of the classic elder abuse is essentially caused by self-neglect? How much, if we got rid of self-neglect, how much other abuse would we get rid of as well? And this says if we got rid of self-neglect, we'd eliminate about a third of all other cases. Now, I can't say this is causal. I have to say we need to repeat it, but I do think this is a very valuable insight into what's going on. So the idea that self-neglect and other forms of abuse are separate doesn't really hold up in either the crude epidemiological data, which is literally what APS sees, or in how we begin to analyze it with the tools that we know how to analyze things. We see that caregiver neglect, caregiver neglect, financial abuse, and physical abuse are the ones that are actually, when you subset them out, also related to self-neglect. It turns out that emotional abuse isn't. It's sort of interesting to me because emotional abuse already occurs in the setting of a relationship. So anyway, this is data that we need to repeat and need to further quantify. But the take-home message here is that if you have a first substantiated allegation of self-neglect and nothing else happens, you will end up back in the system with other forms of abuse. So it also suggests to folks, when you are seeing somebody in a community with self-neglect, be thinking about other things. Be thinking about, is there something else going on here? Do I need to be alert to something? So what is all this telling us? And I guess, Amelia, what is it telling me? That self-neglect is not easily separable from other forms of adult maltreatment. It may account for up to a third of all future cases of CDC-defined abuse. It clearly does not fall into any simple diagnostic category. People have all kinds of theories, all kinds of things that are part of it, right? So it's a bit of a mess. Self-neglect does not have an easily identifiable cause. You can't say, oh, your sugar's high, so therefore you have diabetes. It's not simple. And oftentimes there's a tone of blame. And sometimes I think we blame people because we don't really know what to do. We feel conflicted about it, and we're like, that's on them. Even though as caring individuals, we know somehow we've got to figure out a better way around this. So I think now this gets to the provocative part, and the part that is a little bit of an experiment. So should we begin to reconsider what we mean by self-neglect? So going backwards a little bit, this is a slight cul-de-sac. So what is a syndrome? It's from the Greek word meaning to run together, which is sort of a nice thing. It's like these are things that move together. That's a syndrome. In a more specific way, it's a recognizable collection of symptoms, things that people complain about or will tell you about, or conditions, things that we often call signs, things that we see that occur together for which a direct cause is not necessarily understood. It's like we see it all together, but we don't really know what's causing it. And so there are a lot of common examples. Chronic fatigue syndrome now has a different name, but we know it occurs. We don't really know why it is. People have thought about 27 different ideas. None of it's really true. Post-COVID syndrome, again, we know that. We know people have had COVID, but we don't really understand what's the underlying cause for the things that they're experiencing. Irritable bowel syndrome, I don't know if you've ever had a cramp or loose stools. You may have, again, wildly, maybe 15 to 25% of the population may have it. We still don't really understand why. And really a sort of tragic one is sudden infant death syndrome. It doesn't happen frequently, but we know it occurs and it devastates people. And we still have no real idea of what causes it. We do know that certain sleeping positions will make it less likely. So that's important. And sadly, just as a small sidebar about the incredible importance of data, Dr. Spock wrote a book on taking care of kids, in the 60s. And in there, that was said, how should you put your child to sleep? And he literally said the wrong thing, like basically probably caused more infant deaths than not. And that's because people didn't think about data. People didn't look at it. People didn't say, oh, these small infants are dying. What's going on? Let's talk to some people. Let's get some data. So it's very important for us, if we're saying something, to be sure about what we're saying, to test it and to test it again. So that's why, while I love Rise, I still have trouble falling asleep at night until I know it's been tested again in another state, and then in another state, and in a different circumstance. So I want to begin to think about these ideas somewhat differently. And I think we all know that ourself, our environment, and other people we interact with, that's a crucial aspect of what we're talking about here. So we know issues in terms of the individual. There are issues around personal hygiene, nutrition, medical care. We know that when we look at people's environments, there's hoarding, there's squalor, the homes are dangerous, there's lots of animals or pets. And we also know that people have limited social networks. They're often estranged from family, from friends. So there's a collection, and then we have our cultural aspects to it and our own particular beliefs and the limitations in our communities. But I think it's important to think of what we're talking about, self-neglect, as a constellation of things. I think we've created that. I've probably beaten that drum one too many times today. But relation to the self, relation to their environment, and relationship to others. So neglect is to be remiss in the care or treatment of something. Remiss is not, there's a sense of blame and responsibility there. I'm beginning to think of it a little bit differently, and this is where I'm curious for people's responses. I think for me, it's a syndrome of indifference. Indifference is someone or a circumstance where you don't have interest or feeling in regard to something, detachment. Indifference isn't necessarily a blaming thing. It's just a circumstance. I'm sort of indifferent to that. It's what we see. So how might that play out? What would syndromic indifference be? What would be a syndrome of indifference? Well, they're indifferent to themselves, their personal hygiene, their nutrition, medical care. We think of them as indifferent. They think of themselves as perfectly fine. This is just the way they are. They're indifferent to their environment in ways that we don't experience, indifferent to others that we socially or culturally don't quite understand. So it still is a bit of our perspective on the individual, but it isn't about neglect. It's just indifferent. And the indifference can take a lot of different forms, and it can begin to cause other harms. But I do think it's a little bit different. It changes the perspective. So it isn't so much about how do you stop someone from neglecting, but it's a little bit about how do you begin to get someone to care in a different way. Because caring in a different way, I think, will be preventive and help people in the future. So things to remember, coming to a close here. Half of all APS cases are self-neglect. 75% are self-neglect. And if we include self-neglect is in 75% of the cases, 25% of them are both self-neglect and some other form of abuse. Self-neglect is a likely cause of other forms of abuse in about a third of all cases. RISE is, I have to put the RISE plug in here, folks. RISE is associated with 4 times reduction in APS investigations. But what I want us to do is do this. I want us to say half of all cases in Maine are related to syndromic indifference. That's how we begin to think about things. We begin to think about this as a syndrome of indifference because we don't really have a cause. And people really aren't neglecting. They are doing things differently that we may not agree with, that have consequences for them, that have consequences for their community. But our goal, our challenge, is to begin to get people to care for themselves in a different way. Start with caring. And that's both for the individual and for us. I don't know whether this name will take, but that's my talk for today. And we also have a panel coming up. So I will stop sharing. And thank you all for listening. And I'm curious to hear what people think.
So everyone, here's our chance. We had a lot of questions in the chat. Dr. Lewis, I don't know if you had a chance to skim those, probably not. But here's a chance for folks to put your hand up and ask Dr. Lewis a question. Keep in mind, though, we are going to have a panel after the break to talk more about this issue.
I thought I'd start just going through the questions in the chat. Some of them were asked early, Stuart, and I think you kind of answered some of them as you went along. So
Good.
maybe just go through some of them. So the first question was, to what extent could self-neglect be understood instead as a lack of support? Self-neglect seems to cast blame on the individual for things they can't necessarily help. And then there was a follow-up to her question. Yeah, I'm curious about how the social isolation that is forced on older adults culturally by our society, by their devaluation, might contribute to this light.
Yes, yes, yes. I think social isolation is really important. I think as people age, the problems around isolation exist. I think people have isolation prior to as they get older, but they do get worse. Mobility issues play a role. There's Rachel Lakin, who runs APS in New Hampshire, told me this, which is a story which I love, which does go to somewhat of social isolation and risk. She said, when I was being prickly about something, she said, do you know who used to be the most common reporter of abuse and neglect in New Hampshire? And I'm like, doctors? She said, no. She said, people who would read the electric meter, because they're going to people's homes and they are seeing what's going on there. And they had a small training and they were reporting, but we don't do that anymore. Nobody reads a meter. So even that form of human contact is lost. So I do think both socially, as our society changes, in impact of technology, the natural impact of aging, families moving, all these things are playing a role. Yeah, so I think yes, I think it's important, and the more we do to keep people connected, the healthier they are. We know this. Nobody needs to study that ever again, basically.
There's a few questions that are kind of along this theme. Please explain the definition of a lifestyle that's not okay, as most individuals that are living under certain conditions feel that their lifestyle is okay for them.
I think it is okay for them. I think that it's not so much it's not okay. It's just like what would make their life a little bit better if there's some way to do that. Like, it's very hard. It's a very hard situation. I don't have answers to it, but I think that you have to begin slowly. I mean, coming in with a checklist, coming in with, you got to fix your roof now. They're like, why? It's like, we have to be, how to say it? There are certain situations which are just so clearly unsafe that people can't be in them. I mean, no question about that. I'm not talking about that. Those are probably the smaller subset of most of the stuff we see. But how do you get people to begin to move, like, in ways that are, because we know things are healthier for people. We know connection's healthier. So how do you get people to be more connected, right? It simply could be the APS worker, caseworker, somebody just giving somebody a cup of coffee. Like, that might be how you begin. You might be just literally a cup of coffee and beginning slowly. What do you want? It's person-led. And it may be successful, it may not be successful, but it's probably going to be more successful than coming in and trying to say, you got to do this, you got to do this, and you really should do that. That's pretty much what people have been told throughout their lives. And again, I don't have a prescription for everything for any of it, other than it's about trying to, people often say, meet people where they are, which is very uncomfortable for us. It's really hard for us to do. It challenges us. We need support in it. We need guidelines. We need people to reach out to say, is this okay? Like, what do we, is this even safe for me? So it's a process, but I think if you think about the person as really being indifferent to you, right? They're indifferent to me, right? They're like, right? It's almost like we have to acknowledge our indifference to the individual. And our challenge is, how do we begin to connect? And if we begin to connect, then they can begin to connect.
This
And-
next one, I don't know if you can speak to this or not, but this person's interested in the spiritual and faith-based factors because that is contrary to most other research, which shows these are often helpful to resilience.
I'm not sure I completely understand. I think that folks, at least the literature on folks who've self-neglected or have, I'm going to call it syndromic indifference, have a lot of spirituality and have deep beliefs. So I don't know quite, I think if we can, I mean, they may not be, they're not sort of like, they're probably not people who one would associate with sort of routine beliefs or going to services or church or things like, they don't do that, but they do have deep faith. And I think that is a way that one can connect with them, but I don't think I'm answering the question completely. I mean, I think that it's important to not be prescriptive about things because people's faith and beliefs in spirituality are very individual. I see, is it faith with that religious community that?
I don't know, Quinn, do you want to clarify your question?
Yeah, I was just asking because I work as a hospital chaplain, and we know from a lot of our research that belonging to a spiritual or faith community is a strong tool for avoiding social isolation, as well as a source of a number of coping mechanisms. And so it just surprised me to see that as a common trait of people experiencing self-neglect, when my experience is it's often a tool for avoiding that. And so I'm kind of curious about that.
Well, I would say that they have a strong spirituality, but they're not part of any spiritual communities. Like these are people who
That
have
makes sense.
deep faith, but it is a way potentially of connecting, but also, you know, it's like they may have had a bad experience in a other part of their life in relation to religious faith or things like that. And, you know, I think the beauty of all the hospital chaplains I know is that it's a very inclusive group of people. And not everyone's experience of religion is that inclusive. So, I mean, you know, these are people who may have had a different sexuality or different, I mean, there are lots of different ways people can become less than seen. Maybe that might be the best way to put it.
Are there codes
I hope that
listed?
answered your question.
Sorry. Are there codes listed in the DSM-V?
Good question. I haven't looked in the DSM. There are codes for neglect. There are codes for that all sort of orbit it, but don't specifically say it, as far as I know. And I could have missed it. I mean, these are massive things, but I've looked, and there are things that orbit it but aren't so specific. Like there are very specific codes for suspected physical abuse of an elder abuse. There are very specific causes for confirmed physical elder abuse. I mean, so there are very specific things, and that don't, as far as I know, exist for self-neglect, syndromic indifference. Even I have trouble with my name.
Is the experience of homelessness generally defined as self-neglect?
I sure there are some people who are unhoused where that would be true, but I think people who are unhoused have lots of different causes, many causes. So I wouldn't say that it's a piece, but not the entire thing. But lots of folks, I mean, more often than not, the people who we see, who Brian and the folks at APS see it, something like they are living in a place. They could be in an apartment, they could be in a house. I mean, they actually have a place where they are. They have a physical address. I mean, sometimes a physical address is a car, but it's a physical address. So yeah, I wouldn't say it's necessarily. I think the problem of people who are unhoused is a much broader group of people. And from what, I don't know a lot of the research, but I do know that there are very specific reasons for very specific groups of people. So
So this is kind of a long question, you know, it's about who's measuring the different levels, who decides, who defines, who does not decide based, you know, who funds the treatment. So the elephant in the room is always about economic advantages to age safely, and economically being at a disadvantage who are unable or unsafe based on economic disparities. So it's that kind of, I don't know if we can say that this is across the board like an economic thing, because we see it with people who have
So-
money and people who don't, or
I'm not sure. I guess I'd ask you to read it again. Economic disparity clearly is an important driver for many things that we see in terms of adult maltreatment, for sure. But obviously, self-neglect, you know, syndromic indifference occurs in folks with a lot of resources as well. But I do think that more often than not, it's folks with not a lot of resources. So I think that's something that's important. And also, we don't have a lot of resources to help people. Now, I do think it's very possible some of the ways things get coded by APS is to improve the resources that are available to people. I mean, Brian might be able to talk more about that. I mean, they're not making things up, but they're trying to figure out ways of, like, with our limited resources, how do we help people? What can we do? So, you know, so some of the data is a little bit fuzzy, but I think the direction it's going in is accurate. Feel like
sometimes
might have had a question.
Oops, sorry.
It scares me when Jess has a question, but go ahead.
Sometimes there are cases where an older adult can still make poor decisions, whether we agree with them or not. How are we able to differentiate between poor decisions or self-neglect?
I think everyone is allowed poor decisions at any age. I don't think it's just older adults. I mean, how do we distinguish between poor decisions and people who are, I mean, I think that we have to think about the quality of their lives, where they're living, their sense of social, are they social isolated? Are they estranged? What is the decision? How does it impact them? How does it impact their community? How does it impact, I mean, I think there are a lot of different factors. And is it the 10th bad decision they've made? Or is it just the first? And what's a bad decision anyway? You know, so I think we try to see it more in terms of the life course. But I also think that if we are trying to sustain engagement with someone, whether it's someone who we're assigned to or is assigned to us, or a family member or a friend, it doesn't really help us to sort of like make a big stink the first time. Like, we want to try to see where someone is, because gentle discussion can have someone understand that decision differently. They may change the decision. They may make a different decision in the future. You have no idea. But conflict, in general, conflict doesn't help us, you know, improve, you know, it doesn't really help us get to connection. I guess that might be the best way to put it. You know, I always think, like, when you're in a foreign country and you don't speak the language, so you speak your English really loudly, like that's going to make a difference. Like, you know, it's like, if I speak louder, then they'll understand it. No, not really. But anyway, I don't know if that, yeah. I mean, I think, look, no one can tell you where the line is, because the line changes in time, the line changes with individuals. You know, we all want the line. We would love to have it. We would love to say, that's the beauty of some diagnoses. If you have this and you have this and you have this, and then you have that, you know, if your culture grows E. coli, you've got a urinary tract infection, right? Bingo. So easy. But that is not life.
There was a question just about how to access the RISE program, and Polly answered it. It's a program that's a specific relationship with Adult Protective Services, and all the referrals have to come through Adult Protective Services. And so we have had some people that were concerned about somebody, and we say, well, make a report to APS, and there's a chance that they may get paired with one of our advocates, but it really has to come through that system. I don't know if Stuart, like if there's any, we just get so much interest in this from other groups that are outside of the APS system. Is there any hope in the future of taking this beyond the APS model, or where are you now with the research?
So I know, Brian, I see Brian. I know Brian doesn't want everyone referred to APS.
Sorry, Brian.
But we do want people referred to where appropriate. I think our hope is that we will find a way to expand the availability of RISE into other areas and to other places. Health systems is one place I think that would be very useful. Again, you know, look, it only takes probably one thing, which is money. So I think hopefully we'll find that. I do think the work with APS is really, really important. And the first step really is to show that what we did in Maine, we can do elsewhere. And under some different circumstances and with a culturally diverse group of people, economically, we have a lot of economic diversity, which is great, but we don't have a lot of culture, social, cultural, economic, you know. So to prove it works in other places will allow us to expand into other areas. And that hopefully is something we will do. And I'm hopeful about it. But honestly, even if we just turns out it only works with APS, APS is everywhere. That'd be great. I have no, you know, that would be super. So, I mean, I think we just have to dream a little bit, but stay in reality and test everything we can, because it's so important to know that what we're doing actually does something, and it's not just, you know, for the chief, I began this work a while ago. I was quite interested in policing. I did some work in evidence-based policing, and we wrote this paper, which I feel like it's been cited more times than it probably should be, but it's probably only for the title, which is intention is not method, belief is not evidence, and rank is not proof. So we really need to know what we're doing. And if there's any message I can leave people with, is just really try to know that what you're doing actually ends up doing what you hope it does. And that applies to all of us, I think. I mean, certainly medicine, we have a terrible history of it. So
here's Jess's question.
uh,
Are you able to share your thoughts on the systemic causes to syndromic
indifference? Thank you, Jess.
Or in other words, the lack of investments in the system that creates a safety net, for instance, homemaker and home care services.
Wait, can you read that again?
So are you able to share your, Jess, why don't you just ask him?
I'm just interested in, you know, where systemic shortages or challenges are come into play here. We're seeing, I'm sure you know, significantly more older people, particularly living in affordable housing, who can't gain access to homemaker services and home care services, who are becoming homeless, who are essentially aging into self-neglect because they can't get care, and just sort of what's at play there, and how can we start talking about that as well, as a systems issue, because I didn't really hear that come through, and I think that's definitely at play.
Yeah, I realize I've been actually wearing my microphone on my headphones and it hasn't even been working, but brilliant. So I think, can you hear me? Can you hear me? Okay. I think this is a problem of two sides. Yes, I think there are all these places where we need to begin to invest in our communities. Absolutely. We need affordable housing. We need people we need services. We need all these things. But it's also like I just lost you guys. There's a famous epidemiological parable, which is that you're on a riverbank, and you see all these people drowning, and you start pulling people out of the water, and you're pulling people out of the water all the time, and it's great. But you never think to walk up about a quarter mile to stop the guy pushing people off the bridge, right? So how do we begin to prevent some of this? And some of this is workforce enhancement. Some of this is providing services for people. Some of this is better education. Some of this is retirement. I mean, there are so many ways this plays itself out, and some of it is simply strengthening the bonds in our community. How do we begin to do that? I mean, we have a lot of rural communities where younger folk leave. So how do we make it more interesting for younger people to move back into the communities that they've grown up in? How do we support them in that? How do we create bridges between younger individuals and older individuals? Because we know those connections are what stops abuse and neglect, right? We know those things. So it's both thinking about things where we are, but also how do we begin to build into it? How do we begin to essentially create the right soil to grow these things intrinsically? And I don't have an answer to that, but I do think there's lots of people who are interested in it. And we know that lots of things get in the way. I mean, look, I just always get so depressed when I see somebody like, I call it prayer mode, like that, so I think there are lots of ways we can begin to care for each other more. I mean, I guess that's just what I want to say. Please care for each other.
Thank you, Dr. Lewis, and everyone. There's some good questions. This is going to be kind of a good, last question is going to be a good segue into the next panel, which we're going to begin in 15 minutes. That's about system response. We'll have a couple other presenters joining us then. So if you still had a question that remains unanswered for Dr. Lewis, put it in the chat and we can address those at the beginning. Otherwise, it can come up in the next panel. So it is 10:30 now. I would like to get started again at 10:45. So everyone take a quick break, go get a snack, use the bathroom, and we'll see you here in another 15 minutes. Thank you.
Thank you, Stuart.
All right, folks, we're going to begin in then the next minute. Ellen, are you able to show the third and fourth poll question from earlier? Can we display that at all? Or is it too late?
It is not too late. Just give me one moment.
Okay. So the first question here was if you've worked with someone who's neglected themselves, to what degree were they engaging in self-neglect? Looks like moderate takes it with 60% of encounters, with minimal coming in at 17% and severe coming in at 22%. I think that's probably generally what we see. So we can end that question. And then was there one other question, I believe? Here's the next question. Level of frustration. All right, so most of you have answered by now, and 61% moderate in terms of level of frustration, with minimal coming in second at about a quarter, 25%, and then severe coming in at 13%. Thank you very much for those poll answers. And we can stop showing that. And we'll move on to our next group, is a panel discussion talking about system responses. And that's going to be, of course, Dr. Lewis, and he's going to be joined by Brian Day from APS, Danielle Malcolm from the Long-Term Care Ombudsman Program, and Lauren Willie from Disability Rights of Maine. So if those three people are ready to go, we can begin. Dr. Lewis. When you're ready, if you guys have questions, please put them in the chat and the panel can discuss like we were doing at the end of last session, but we have more subject matter experts here to help out.
God, I'm so sorry. I seem to have trouble with my mic and my headphones today, but there we go. Thanks so much, Chief. So we'll have a panel discussion, considerations in the system response to self-neglect. This is the time where I get to listen to three actual experts and learn something, and then we all can begin to think a little bit more about what we've been talking about today. So we're going to try and think about this in terms of what are the systems that are surrounding folks with syndromic indifference or self-neglect, and how might we begin to improve their circumstances. And I'm really grateful to have three really extraordinarily gifted panelists with me who intersect in various parts of these considerations. Danielle Malcolm, who's at the Long-Term Care Ombudsman Program, Brian Day, who is at Adult Protective Services, I think recently just was back to his usual day job of not being in charge of APS. And I think that's probably why he looks more rested. And Lauren Willey from Disability Rights Maine. So hopefully this will be a pretty broad discussion. I think we'll definitely get a chance to get some more questions in. I think that will be quite helpful. And so I guess, Brian, just if you could start with your perspective on this, and how does APS define, I know you call self-neglect, I'm not expecting you to use my term today, and some of the, let's say, places where you feel, the places where you've had successes and what's been part of that.
Sure. Thanks, Dr. Lewis. I am Brian Day. I was an acting associate director of APS until just recently. Gina Guggens, who may be in this call somewhere, shout out to her, is now the associate director. But I'm still with APS. I'm a program administrator. So my specific region is up north in Aroostook County, but oftentimes I'm working with the other PAs from the other regions as well. So I may speak with any of you depending on what the case is and who's covering that day. So Maine APS looks at self-neglect as the deprivation of essential needs or inability to protect oneself. When we're talking about the deprivation of essential needs in the context of self-neglect, we're basing it on either the client's actions or their inactions. So in contrast to a neglect where we may be looking at a caretaker and what they're doing or not doing to provide for a client, self-neglect is looking at what the client is doing or not doing for themselves. And I use the term client as like a blanket statement to refer to adults who are incapacitated, independent, or dependent. I won't get into that definition, but if there's questions on it, happy to have that conversation later on. But our definition is very similar to the Elder Justice Act definition that Dr. Lewis had shared at the beginning of his presentation. And we expand upon that term of essential needs to include basically food, clothing, adequate shelter, and medical and mental health care, as well as access to appropriately taking medications. So I guess basically self-neglect is when a client is refusing or unable to perform essential self-care tasks. And I know that term refusing does place some blame on the individual, as we had spoke about earlier. And then there's also the piece there where they're unable to, where maybe they do want to engage in this care, or they would if the circumstances and their environment was different and more conducive for that. So that self-neglect term is broad, and we further break it down into some specific categories. One of them is a decline in self-care, where maybe a client's needs have gotten too great for them to be able to manage on their own without a caregiver in place. Having access to food, that's a pretty basic human need. So too with clothing and shelter. And then separate but similar to having safe housing is hoarding behavior, which is something Dr. Lewis had touched upon before, which could be a symptom of self-neglect if it has limited access to being able to move about the home and being able to enter and exit safely. Personal hygiene is another example. And then a client not managing or being unable to manage their existing finances, not to be confused with making poor financial decisions, something I'm guilty of myself, but really they're unable to manage their money because of some kind of physical or cognitive limitation that prevents them from being able to do so. So self-neglect is a very broad category. The APS response depends on really client-specific factors. And that includes their environment, the resources, informal and formal supports that are available to a person. I think the second part of your question, Dr. Lewis, was an example of success, and not to hop on the RISE train too much, because I know we're affiliated with it, but the RISE program has been very helpful in helping to mitigate those clients who keep coming back for multiple referrals, and being able to have that, I guess, that longevity of relationship with the client. From the APS perspective, we definitely try to build rapport and to work with the client, meet them where they're at, and try to provide them with services or access to services that are appropriate. Oh, sorry about that. But we also have time limits and how long an investigation can remain open. Whereas with the Elder Service Connections program, the advocates from the Elder Abuse Institute of Maine, they don't have that same time frame. And so if we have to close one case and move on to the next, but we can hand that case off to an advocate, they can really work with that person long term. And some of those interventions that we started at the point of an investigation can be carried on in our absence as we move on to the next case. So that's something that I find to be very, very successful. And on that same vein, just really working with our community partners and collaborating. Some regions, some towns have more access than others, and just knowing who your players are in those particular areas can really make a big difference in trying to stage an intervention and help someone out.
Brian, may I ask, so how do you assess when somebody needs a more dramatic, how to put it, and maybe intervention? Like, how do you folks begin to do that, and who do you bring in for those decisions?
Yeah, depends on the client and what their living arrangement is. Sometimes, and I know there's been some mentions in the chat, which very interesting chat, by the way. I'm pleased with the responses and the questions that have been generated. So keep those coming, because I love to talk about this stuff. But there's this idea of like class. And sometimes when a referral comes in, it may just be like a person's middle class values, not having this perspective that the person isn't living safely, even though that's just the way they live, and it may not be up to other people's standards. And so when we go out for an investigation, we would assess, like, is this person truly at risk for health and safety? What is their home like? And, a home can be messy, it can be cluttered, and still be safe, or what the person wants. But then the response heightens depending on what factors are in the home that may be unsafe. Like poor hygiene on its own, for example, it may be unpleasant, but that's not necessarily a serious risk. Poor hygiene when you have a wound and you haven't been receiving proper wound care, that kind of escalates it a bit. So then we try to see if what the person is willing to do. Like, hey, that doesn't look right. Can we go to a hospital? Have you seen your doctor recently? Does someone coming in to care for you? And depending on what those responses are, we may work with the services that are available, try to get services in, or we may call for an ambulance and be like, hey, this person really needs to go. Like, they're not in good shape.
Thank you. That's quite helpful. I'm sure we'll get, I know there are some questions, but we're going to shift a little bit to Lauren. I know there are tools for someone to pre-plan or to help plan for supportive resources, and perhaps that can be tailored to them. I'm curious as to how some of that can be brought into this response system.
Is my microphone working?
Yes.
Great. Thank you very much. And also thank you, Dr. Lewis, for referring to us all as experts. I just want to be upfront that I don't necessarily consider myself an expert on self-neglect or anything really, I suppose. But my job at Disability Rights Maine is I work maybe obviously primarily with people who have disabilities. And there's a lot of overlap in issues that relate to people with disabilities as well as people, older people. So but with regard to your question, I think I want to talk for a minute about normalizing talking about planning, because I think a lot of what we talk about when we talk about self-neglect is a little bit too far down the road, right? When I think about people aging, I think about autonomy, I think about self-determination. Those are the big things that I think about in working with my clients who have disabilities. And so really creating incentives and destigmatizing all of the issues involved around needing support, wanting support, asking for support, aging, destigmatizing that. Because I think really at its core, when we talk about self-neglect, you really, it's so important to have buy-in from people who are at the center of these services. And that's what I sometimes see lacking is this sort of lack of resources, lack of incentive for people to ask for help. So when I think about pre-planning, I think really most fundamentally about destigmatizing and normalizing conversations with people about what is it they want as they grow older, what kind of supports do they want, so that we could avoid this entire conversation in the first place. So some of the tools we talk about at Disability Rights Maine, we talk a lot about alternatives to adult guardianship, because our real priority is to have people maintain their civil rights, have control over their own lives, to have autonomy and self-determination. So some of the tools we think about, or we talk about when we talk about those things, are something called supported decision-making, which is really a model and a tool for people with disabilities or people with any kind of support needs to make their own decisions. So it's like creating a plan basically for people at the center to be able to make their own decisions with support from people in their lives that they choose. So that involves thinking about what kind of decisions do I want support with? What kind of support do I want with those decisions, and who is it that I want to help me with those decisions? So that could be friends, that could be family, that could be service providers, that could be medical providers, all sorts of things. So that's one tool we think about. We also have just the whole array of just estate planning tools. Just as an attorney, I always think it is a great thing for people to be thinking about powers of attorney, which is a legal tool that will allow someone to share the ability to make decisions with someone, a trusted person, a spouse, an adult child, a good friend. So, if I'm not able to make medical decisions because something has happened, I've pre-assigned someone to sort of step in who has my values, who knows what I might choose for myself to be able to do those kinds of things. Advanced healthcare directives are another way to do that. They're very similar to powers of attorney. So it's sort of communicating what future me might want under certain situations, and having some sort of trust that the people that I've assigned are going to carry out those wishes, should or if the time comes. And I also just, again, like just sort of normalizing, I think the sooner the better. I don't think we should be waiting to have these conversations when we need to have them. I think we need to be having them before we need to have them, so that we're all sort of acclimating ourselves to the idea that, we might have support needs, and needing support is not the same thing as necessarily capacity, right? If someone needs support for something, that doesn't, to my mind, mean that they don't have the capacity to make a decision. So I don't know, those are things that I think about. I think, the sooner we have these conversations, and we think about these things for ourselves, the better.
I totally agree. And they're not easy conversations to have either with loved ones, or even conversations inside your own head. I'm curious about perhaps the language that you use, or the way you help normalize some of these conversations.
I wish I had a direct answer to that question, but I think about a few things when I think about like sort of stigma and normalizing these conversations. I think when I think about pre-planning aging, needing support, I think about not, and this isn't a dig on anyone, because these are terms that have sort of risen around us, and we're using terms like self-neglect. We didn't create those. But even the way we talk about it, I think creates stigma, right? Self-neglect sounds like it sounds like a very accusatory. Allegations, investigations, substantiations, like the language we use when we talk about someone who might need support in things, just at the outset, I think creates like a disincentive to seek help.
I think that's completely true. And I know that part of what you are grapple with at times is guardianship stuff, right?
Yes.
And I feel like there are interesting stuff that your office does, and because guardianship comes up a great deal in terms of folks who APS sees, especially in these situations. Do you have any comments on guardianship or things that you may have just even that might not be fully cooked, sort of information about Maine and guardianship that might be interesting for all this?
Yes, I could talk all day about guardianship, but I'll just talk for a minute about guardianship. We do a lot of work around guardianship. We do technical assistance. We directly represent people in either defending against guardianship or terminating guardianship. And Maine's probate code was updated. The probate code is the law around adult guardianships. Guardianship, I just at the outset want to say, is like the most extreme removal of civil rights for a person outside of maybe incarcerating them. It's taking away all of their abilities to make decisions. So it really is a very extreme measure. And when the law changed or got updated in 2019, it really, really strives to emphasize less restrictive alternatives and really sort of hammering home that idea that if there is a way to support a person in making their own decisions and support in sort of accessing services and things like that, then they should not have a guardian. And I tell my clients all the time, if you are telling me that you need support with things, that is a good thing for me. That's an argument I can have that you don't need a guardian because you're recognizing and you're asking that you might need support. So to my mind, quality of life is very closely intertwined with having the life that you want for yourself and not having people step in and make decisions for you. Even decisions that you think that you want, I think is, it can be really dehumanizing to have someone saying, this is what I've decided for the person, this is what they want. Living your whole life and then sort of having that autonomy taken away from you. So we do a lot of work with guardianship.
Great, that's encouraging. I know Judy Shaw had a question. I'm not quite sure how to handle the questions for the moment, but I do want to say this idea of autonomy and meaning is really essential. There was an amazing study done in the 1970s where they took a nursing home in Connecticut and they gave they gave everyone a plant who wanted a plant. And half of them, they said, look, this is your plant. You water it and you'll deal with it. And then the other half, they said, we'll water it for you and take care of the plant. And then a while back, they just came back to see what happened. And amazingly, the people who were responsible for their own plant lived longer than the people who had the plant watered for them. And it's been repeated in a lot of different ways. So responsibility, taking care of things for yourself, autonomy, all these things make a big difference. So, and I think maybe it would be, so Judy Shaw's question, would there be value in making supported decision-making the default generally and use powers of attorney for the time when one's ability to make decisions is far more limited? Also educating people on their respective roles. An agent under a power of attorney still doesn't get to substitute their judgment for the principal, but we see that all the time. I mean,
yes to all of that. So I think by default, at least under the law, all of those things are supposed to be default before we take away someone's rights. A power of attorneys are really interesting and like flexible legal. First of all, the person making the decision is the one in charge of the power of attorney. So I can revoke it if I want. I can also craft it in a way where, you know, I believe it's called like a springing power of attorney, where someone does not get to make decisions for me unless and until, you know, some future event happens that might impair my ability to make my own decision. But it all is very a misunderstood instrument. And I do think that sometimes people believe that you have a power of attorney over someone. That means you get to substitute your decision over what they are saying. And that is 100% not true. It's really about sharing decision making. And like I said, a person that has a power of attorney could tear it up at any moment. You know, it's very different from a guardianship, which is court ordered. It's supposed to keep the person in control. I hope that answered your question.
Well, we have more time for questions. So, and Danielle, if you, for long-term care ombudsman program, I wonder if you could talk about some of the shared factors in self-neglect or syndromic indifference in certain situations, and how do you approach that? And I know that it's slightly different in the long-term care ombudsman's office because of the responsibilities that you have, but I'm curious as to your perspective on these questions.
Thank you, Dr. Lewis. So a lot of it we've already discussed. We talked about isolation. We've talked about living in a rural area, access to resources. But one area that we haven't talked about yet is the power of understanding your rights, especially as you enter the long-term care world. I always tell people to try to think about getting a phone call right now that there's a stranger coming into your home this afternoon, and they're going to give you a shower and help you go to the bathroom. And, you know, if you don't accept that care, you're being challenging and the vulnerable position that puts you in. So if you start services in that way, I think you're going to see a lot of pushback, and sometimes that's looked at as self-neglect. But really, I think what we're missing is, let's start with what someone's rights are before they even enter into any of these programs. So it has a conversation happen where they understand that they decide who that person is when they come in, what area of the house they're allowed to go into, what gender that person is, the ability to meet them first and decide what days of the week they come into their home. And when you give them all this power first and make sure they understand their rights, I think they're a little bit more accepting. The same goes for, we see a lot of people who appeal their Maximus assessments and they reach out to us, and that is to assess them for what they qualify for home care or for placement. And they're either reduced or they don't get the hours that they want. And we sit down and we go over the assessment with them when we talk about everything they need help with. And we'll talk to them about, you know, can you get out of bed in the morning? And they'll say no, but we'll see in the assessment that they said that they do that independently. And a really common theme that we hear is that, you know, I was just really nervous that this assessor was going to see what a hard time I'm having, and that they were going to tell me that I need to go into a facility. There's a lot of misinformation about what it takes to get someone to a facility. There are people who really think they're going to have this assessment and someone's going to show up and there they go. You know, they don't have that choice, and I don't think they understand that they have control of that, and that they, you know, to force someone into an institution, you know, is quite a process. It doesn't happen overnight, and there are resources if for something like that were to happen. But I think we need to start the conversation with, at this assessment, the word nursing home might even be brought up. You're nursing home eligible in the community, but all they hear is nursing home, and immediately there's a red flag, and no, I don't want that service. I don't want to be involved in anything that even has that word in it, because of that fear of being institutionalized, which I think we all, you know, probably agree with. And I think if we start our conversations around rights, both with facility placement and around home care, that will help with some of the misunderstanding there. And the same goes for other areas of long-term care. We have people that will say that their family member is POA and they're pushing for them to be in a, you know, to go into an institution. Oftentimes they don't know what's in that POA. They don't know where it is. And sometimes it doesn't even exist. So really that self-advocacy piece of let's get a copy of it, let's read it, let's determine what it even says. Most of the time it ends up being that it doesn't even allow for those types of decisions. And we see a lot of the misinformation also around main care and estate recovery. We have people who are afraid to access main care cover services because there's a lot of misinformation about that means someone's going to come take my house, you know, and estate recovery has a lot of rules and regulations and can be sometimes difficult to navigate, but there are experts and resources. So I think it's starting with focusing on what the fear is and really addressing that with giving them the resources and the knowledge before we push them into a system that is sometimes makes them feel very vulnerable.
It makes a lot of sense. I'm struck by the shame involved in these, which I think when anybody comes in to assess somebody, your natural impulse is to try to obviously say you're better than you are. This is just my own naivete. Who does those Maximus assessments?
Well, I called it a Maximus assessment. It's done by Maximus. They're
Is it
actually
like on the phone or something, or somebody comes to the house?
It's in person. Yep. And it's called the Medical Eligibility Determination, the MED assessment. And it's had, you know, different vendors that do it, but currently it is Maximus that does the assessment. So they send a nurse out and it's a pretty lengthy assessment and they're asking about how you, all of your activities of daily living, from how you eat to shower to use the bathroom. And I think sometimes people aren't prepared. Or maybe they have a loved one with them who they're a little bit embarrassed to speak about their true needs in front of their adult child. So we do a lot of appeals with those, and those appeals are hard because the assessment is accurate based on the information that was shared at the assessment. So there's no argument that it's technically wrong. So we have to try to look for another way to get a plan of care that's going to work for that person.
Wow, that sounds yeah, there's certainly the theme is knowledge and communication, both in terms of the pre-planning and also in the moment when people have needs. And also, I mean, I do think people always think when APS shows up, they're going to a nursing home. I mean, I think that's a big fear. Right? I mean, you know, it's like, I'm from the government, I'm here to help you. It's not generally, I mean, people don't generally view that with a great deal of trust. So they're very hard situations. And it just makes me curious. I just wonder in terms of things that could possibly come out of this. Like, since when I do know that there's a massive, you know, workforce issues in relation to personal care services and other things that are necessary for people. But if you spend 20% of your time or more, you know, fighting Maximus, that's probably 20% of your time you could be doing better things. And whether there's a way to facilitate how these assessments are made in ways that would be person-led or ways that would, you know, I'm sure like these are folks who are quite traumatized. I'm sure that the people coming in are not taking a, you know, trauma-informed approach to asking people about like how they shower and their daily activities. And it does seem like a place that one might be able to educate or to improve the system so that Maximus isn't involved in you know, appeals. Like, if everyone gets a more accurate assessment, everyone benefits. So I wonder, are there ways of coming together around? I don't know, just I'm curious about that. So I don't know what you guys think about that, but you know, Because I think, Brian, I mean, in terms of getting main care eligibility, that's a major aspect of one of the benefits that I think APS is able to do. And how do you best,
Yeah, I mean,
how do you put these things together? How do you basically educate in ways that will make your jobs easier? That would be my hope.
Yeah, particularly for self-neglect cases, and as we had mentioned, there's this related component of having limited socioeconomic resources. So sometimes we may be going to a situation where the person may be financially eligible for main care, but they may not have had the means to apply for it or access it. And so we can kind of assist with that. If there were other concerns that led to their APS report, we could help guide through that process so longer term they could have access to it. I mean, certainly can't guarantee eligibility for the program, but we could help get that process in motion. So that's one part of main care eligibility, is the financial eligibility. And then the other part, as Daniel was mentioning, is the medical eligibility in completing the assessment, which people have their inclinations to not always be honest in completing them for the many reasons that we spoke about, shame or embarrassment, wanting to come across as an independent person, as we all do. And so I'm not sure how to overcome that piece, aside from having rapport with the person and supporting them through the assessment process.
Yeah, it's an interesting, anyway, I know it's not quite what we were talking about, but it does feel like a very vital portion of this, of like, how do you help people get the help that they are actually eligible for and need? It does seem related to the ideas of how do you get people to be able to listen and change and care. So I guess it's something for us to all think about in the future. Amy, is it Cutliff said primary care doctors should be educated on helping patients with this? I totally agree. Although I wouldn't count on us to be able to do it in ways that will be effective. So it feels to me like to me, it almost feels like whoever's coming to the house to do the assessment is the person that we would want to talk to somehow, or to have some standards in place or training, or anyway, who knows? I think that that's just a part of this whole set of issues that are related, because I think everyone's best served when they're safeguarded and their autonomy, for want of a better word, is of primary value, and also it helps that individual have a better sense of well-being and probably have a better life. So I think all those things are related, and it just sort of sounds like, in so many ways, these are just places where there are a lot of good things that are possible. There's a lot of, and they're not hard, they're not complicated things, but getting people to understand them, getting that message in ways that people can hear, seems like a big challenge. So whether it's like how to have these difficult conversations, right, which everyone has, like, but how do we help people do that? Or how do we help people be more confident in the system around them? And maybe that's sort of like a way that maybe that's another question for us to talk about, which is how do we get, because we're all involved in systems. I'm in a health system. Brian is in adult protective services. I guess, I mean, Lauren and Danielle, you're not quite in a system, but you're sort of like, I think, are sort of like either fighting the system or like trying to make the system better.
I think we bear witness to this.
Or you're just, yeah.
I wonder, Dr. Lewis, if I could also just add one piece that I'm not sure we've talked a whole lot about, and that is the availability of services. Like you can pre-plan and think about what it is you want for your life all day long. You could have assessments all day long, and those are absolutely necessary things when we think about pre-planning. But if those services that you want or you need are not there, all the rest of it is for nothing. And so I think there's also, just as a society, as a state, as a country, we have a lack of funding for community and home-based services. I know this professionally, I know this personally. Just it is, and there are so many people that I work with that, you know, might be engaging in so-called self-neglect that do not need a lot of assistance. This might be a person that needs someone coming in a few times a week to help clean or cook, or, you know, a few hours a day. And there's a lot of reasons why those services can be so hard to access. I think we all know there's staffing shortages, there's lack of funding, the rates are low to provide these kinds of services for people. But sometimes just the answer seems so simple to my mind, but if the service does not exist or is not available to be had, it creates this insurmountable barrier, when I feel like sometimes just the answer is so obvious, but it's just unattainable at the same time.
Yeah, and it also probably makes the situation worse, because once you tell somebody, oh, you're eligible for these services, and then you actually can never get the service, how is that person really going to trust you ever again? Or what is that? You know, that's just a prescription for massive amounts of frustration. Yeah, and I think I don't think anybody on this, anybody on the Zoom would say, yeah, we've had enough services. We're fine with that. We're good. I think everyone recognizes that it's an incredible need. And also, on the other side, which I think is important to mention, I mean, less so in terms of the self-neglecting, although I think it is related, is that often the burden of care really falls on women and daughters or granddaughters. I mean, this is where people's health is compromised as caregivers. This is where people's careers are compromised as caregivers. So it's really, it's a significant social cost. So I think all of those things are important. And, you know, it's like, how do we begin to make these changes? I want to open us up to questions if there are any.
I didn't have a question, but I just wanted to elaborate on my comment regarding educating PCPs and everything. I come from 2 years of Seniors Plus Care Coordinator for Maximus and Home Care Assessments.
Oh, wow, cool.
And now almost 3 months into Adult Protective. So this has been the biggest thing that I have learned with Seniors Plus starting it, is educating these people over the phone and what the Maximus services are. I mean, ideally it would be great to have a video or pamphlets or more, or the aging and education, the AAAs being able to have somebody primarily having this education to be able to talk to people about this, because 90% of all the people I've spoke to, once I educate them and take that fear away, and let them know, you know, you really need to have no capacity before we can do anything, to a degree. But that was just what I wanted to share, that it has been challenging walking through the door. I'm Amy from Adult Protective, you know, it's the first thing I have to say. And it is challenging. But I also educate them on what we are. And that's been the first step in building rapport with people. But I just wanted to share that it would be nice to have more people, not an APS person, going in and educating somebody else, being able to educate them.
Yeah, that's an important point. And I think AAAs and things like that. So I think it's all crucial, but I'm glad that, you know, at least we have people thinking about it, and maybe that's one thing that can come out of this, which was to be, you know, some sort of concerted effort to try to improve communication around these assessments as best that we can, and whether it's a pamphlet or whether it's a, you know, something that, you know, that somebody could drop off, or even if it's something, you know, oftentimes there may be some local, you know, volunteer ambulance corps that's going into somebody's home in rural areas to give them, look, you're going to get called by these people, and this is so ways of finding trusted messengers is always, I think, important. So I'm trying to look and see if there are other. Some would love to see an info sheet about Maximus assessments that cover area that cause issues. Yeah, it sounds like there's really so much that can be done. And so Hillary mentioned falls on women because care and emotional labor are projected onto women actively by society's expectations that they will do it and that men are exempt. Everyone uses this language, but it really isn't accurate. Hillary, do you want to expand on that a little bit, or?
Whoops, there, yeah. I'm sure. This is just something that I've noticed a lot, and I'm an anthropologist and have done a lot of research on families and households. And I've also noticed that whenever someone writes about the unequitable or unfair division of labor in families and households, which is one thing that we've addressed here in terms of caring work, that is a phrase that we always use. It's a kind of just the default phrase. Oh, it's unfortunate, but it falls on women. But in fact, I have, and I've, articles in the New York Times, scholarly articles, everyone uses it. And we don't think about it too much, but I think that it's wrong because it's not falling on women like the sky falling on Chicken Little, randomly. It's something that as a society, we're actively projecting onto women in addition to all of the other expectations. So that's why I like to just bring that up and raise it for something to think about. Yeah.
That it's baked into our system, that it's part of our system, that we are trying to.
And it helps to perpetuate that expectation, because if we think, well, oh, it just falls on women, then that seems like, well, that's just the way it is. But it's an active process.
I think that's quite true. Thank you for bringing that up. I'm trying to think if we've got some new messages. And yeah, so I'm trying to put some of this stuff together. It sounds like there are so many places for us to help, and so many points of care that need to be addressed that I think sometimes it can feel a little bit overwhelming. But I think that the places for me, what I'm hearing is that if we can begin to do work earlier in life, like whether it's estate planning or education, anything along those lines, it will have benefit. And I think for Lauren, I get the sense it's like, and it doesn't hurt to try, even if you don't actually succeed in your first conversation with somebody. I think that's an important factor in all this, that we tend to be discouraged. And I don't have an answer about how do we stay encouraged, but I think if we, the only analogy I can make, and it's not a good one probably, is stopping smoking. Like, it probably takes people a long time to stop, a lot of tries, but then they may eventually get it. And it doesn't mean you failed, it just means you haven't succeeded. So in terms of thinking about how you bring stuff up with friends or family or things like that, it's like continuing to try with the expectation that the first time it's not going to work. I mean, how many times, I don't know what the right analogy is, but like baseball or tennis, or like how many times did you miss the ball before you finally hit it? So we can have the expectation that it's probably not going to work the first time, but that we can in fact continue to try because it might work, or it might work when somebody else brings it up, or like when the third person who's not a family member brings it up, you're like, oh yeah, I've heard this now, I should probably think about that. So building our own muscle for trying, I think, is important. And I think that Danielle, what I feel like the issues around shame and the issues around how are we honest about our needs, and how are we able to communicate that in ways that we feel like we're being heard, and that the person who's coming in to, quote, assess us is there to help us as opposed to assess us, is very crucial. And I think that this is where, you know, training and education and the language that we use is really essential in it. You know, so something I say to medical students a lot is, because they'll often say to a patient, "Can I weigh you?" And I'll say to them, "Of course you can weigh them, but may I weigh you is probably a better way to approach it." So the language that we use is very important in terms of setting a tone and allowing people to begin to come forward with what their needs are. And that also goes back to sort of the things we were talking about, I think, earlier, which is you beginning slowly. Because the other thing I often say is, as much as that person is assessing you, you are assessing them. And it's like the one thing, I mean, I can only, you know, when I tell students, and I know it's like you are putting your eye on them, and they are putting their eye on you just as hard. And so being aware of the fact that this is a two-way, this is a communication, really can help you to understand how you begin to form, I mean, it is to some extent a therapeutic relationship, but how do you also like help you do your job better? Like, I'm sure everyone would rather have Maximus do more accurate assessments than going back and forth with all this other stuff, right? And everyone would prefer that we have some kind of power of attorney that we could know where it is, because then the hospitals like don't get saddled with ideas around guardianship. And I think Brian would love to have another set of words that wouldn't be, "Hi, I'm from Adult Protective Services." I don't know what that is. You know, they're like, "Are you really here to protect me? Or are you here to do," you know, so all of these things are important in how we think about it. And I think that the challenges around syndromic indifference, self-neglect, are the challenges I think that we face as communities, which how do we allow for everyone's differences, but at the same time support all of us in finding the lives that we would like to live. Because fundamentally, we're all better off when everyone's better off. It's like, you know, I think that that's, you know, it's a goofy expression, you know, a rising tide lifts all boats, but it really does. And we know from all kinds of evidence in healthcare and other places that the more agency, autonomy, the more meaning people have in their lives, the longer lives that they live and the healthier lives that they live. We know that the less isolated communities are, the happier people are. We know that the more communities are cared for, the less crime that there is. You know, we know all these things. We know that if you green a space in a city that's been under disrepair, that you get fewer calls for service there. We know all these things. How we begin to put them into play requires all of our efforts, I think, in a lot of different ways. And I think I'm so encouraged by the group of people that are here and all the hard work that you do and all of the caring and all of the struggle and all the frustration. That's evident. And clearly, you know, you've made choices to do this, and those are deep and meaningful. And I just hope that you can all find the support that you need in doing the hard work that you're doing, because that's the only way it's going to get better. And so I really just say I'm grateful for all the things that you do. And anything I can do to be helpful or supportive, I'm happy to. And I found working with the folks in Maine to be incredible. incredibly meaningful experience in my life. So I think my time said I had till 11:40. It is now 11:39 according to my iMac. So unless there's some other burning questions, unless there's something I've missed, Chief, that you'll let me know, you can probably have your lives back.
Yep, no, I think that was a good coverage. We do have a little bit of time if there are any last minute questions for any of the panelists here before we break for the day. So if there is a question you have for either Brian or Lauren or Danielle or Dr. Lewis, now's a chance to bring it up. Not seeing any. I did have a question, Dr. Lewis, that came in earlier in your first presentation. Is your slide deck going to be available for the attendees?
Sure. I think I made a couple of last minute changes. I'll email it to Jill so that they can have that.
Perfect. And for the group, just a reminder that, again, if you need some kind of legal education credits, get a hold of Jill Randall in her email. She put it in the chat a couple times here. I want to remind people that our next session is Thursday afternoon at 1 p.m. And we're going to have a variety of topics Thursday. I will be presenting a little bit on some of the engagement efforts that police do in the state, kind of working within different coalitions and council groups, as well as some of the regular policing efforts. So hopefully everybody will attend that because I get to talk about that. We'll also have some other presenters and kind of giving more of a prosecutor outlook and other stuff like that. So World Elder Abuse Awareness Day is coming up on, I think, June 15th, and we have some social media stuff to share for it. So in your respective organizations or social media, you can check out the Maine Council for Elder Abuse website. You can download some of that social media presentations for World Elder Abuse. Certificates of attendance will come out after this Thursday's session. So make sure you're on the list for that. And if you have any questions, you can email any one of us within the council for clarification. I'd like to thank Ellen Parent from the Maine Credit Union League for running this Zoom meeting today. I'd like to thank all of the panelists and Dr. Lewis for taking time out of their day. We have a lot of subject matter experts, and we could probably take a whole week to talk about the self-neglect issues that we see. It's a big topic. With that, is any last minute questions, please shoot us an email or shoot us a comment. But in closing, thank you everyone, and we will see people again Thursday at 1 p.m. following the same Zoom link.
Thank you so much.
Thank you all.